Well, welcome everybody. This is Robert Dribbin, and on behalf of my co-chairs, Bruce Sherman and Dwayne Putnam, the three of us are co-chairs of the Center for Employer Engagement, which is one of the 6 centers in the Patient-Centered Primary Care Collaborative. Our focus within our center is on employers, just like the name suggests. Our focus is on getting employers more engaged in the patient-centered medical home model of healthcare delivery. We are thrilled to have this webinar today. It's really an event that grew out of the PCPCC stakeholders meeting that took place on March 29th in Washington, D.C., where our speaker today was a speaker. And the talk that she gave during that stakeholders meeting was so well received that we felt that it was quite necessary to get her on the line and speaking with everybody who didn't hear that talk on March 29th. We have on the line Diane Davidson, and the subject of today's talk is how her company, Roy O. Martin, down in Louisiana, took steps toward connecting their employees to a patient-centered medical home. So with that, let me turn it over to my co-chair, Dwayne Putnam, and he'll introduce Diane.
Thanks, Rob. So, Diane, if I may, I'm going to put in a quick plug for the booklet that Rob mentioned that our center released in March, which is a patient-centered medical home performance metrics for employers, realizing that the employer community has awareness of patient-centered medical home, I think appreciates the value that patient-centered medical home could offer them and their employees, and yet there's still questions about how to evaluate what does good look like. So in the booklet, there are metric categories that an employer can look at. There are case studies, which, as Rob mentioned, is how we found Diane and what Roy Martin has done. And there are steps for an employer to follow. So in the case studies, there's Whirlpool, Boeing, QuadMed, Calhoun County, which would include Kellogg's and the Kellogg's Foundation. You have Merck, the state of New York, and then Roy Martin. So as Rob said, when Diane presented, she got the audience fired up, but we just ran out of time, so we asked her to come back today. And I think what makes Diane so powerful is her background. She's a graduate of LSU with a degree in quantitative business analysis. So she likes metrics, and I think that's the key to success with a lot of this work, with a minor in computer science. And she's also the past chair of the Louisiana Business Group on Health. So not only is she analytical, but she also does a good job of networking and I think expressing what keeps employers up at night. So Diane, we're just really pleased to have you on, and I do want to say if anyone has any questions, we're not going to interrupt Diane today with questions, but we will address those at the end of her presentation. And on your screen, you should see down on the right-hand side a box, maybe open, maybe closed, but it says questions. So please type in your questions there, and then we will answer them when Diane is done with her presentation. So I think with that, Diane, we're ready for you.
Okay, thank you, and thank you for that nice introduction. To begin, we are going to take a quick poll to see what our audience looks like. So if you don't mind, please take a second to tell me what stakeholder group you are associated with. And I know that Cheryl with the Louisiana Business Group on Health is on the line, and so she doesn't fit any of these categories. But if you don't, then that's fine. But I'm just trying to find out who our audience is. So Okay, so we have a very good mix. 37% providers, 23% employers. Well, actually, geez, you're going to make me do math now. 50% employers, so this is great. This is kind of what I wanted to know. So I think we can go ahead and get started then. Okay. So let me start by saying that I'm sure everybody that is on the call knows who Roy O. Martin is in tiny little Podunk, Louisiana. But just in case you don't, I'm going to start by telling you who we are. We started in 1923, and we have been privately owned by the Martin family since then. We made it through the Depression, and so far we've made it through the recession, and so we are doing fine. We are grateful for all our many blessings. We are the largest private landowner in the state of Louisiana with over 600,000 acres, and we manufacture OSB, which people sometimes call wafer board, plywood, so some treated poles. We are very dependent on the housing market, so it has been a little bit stressful for us in the last few years. We sell worldwide, all kinds of different countries, Korea, Japan, all over the place. And we're headquartered in the smack in the middle of the state of Louisiana. If you think of the boot, we are the ankle. And we have been here since the very beginning. And we now have expanded a little bit into Alabama and Arkansas, but for the most part, we're in Louisiana. And we are FSC certified, and we are land stewards. So we plant 7 trees for every one we cut, and we're very proud of being very conscious of our environment. So, and we're proud of that fact. So let me tell you a little bit about our benefit structure. We are self-insured and self-administered. We do pretty much all of our own customer service, even though we do have a third-party administrator through Blue Cross Blue Shield of Louisiana. The main reason we have them as a third-party administrator is because we wanted to tap into their discount network, and that has worked out very, very well. So when our employees call in with a question for their personal health, they're actually calling us, which we are a staff of 4 that do this. And so our employees have a choice of a high or a low deductible. They pay about $3 a week for the high deductible for an employee only, up to $40 a week for a family. For the low deductible, they'll pay $13 a week to $90 a week. So they don't pay a whole lot in premium, and we do cost share. About 64% of our employees choose the high deductible plan, and what happened when what's happening that we have found out as time has gone on is that when people have a high deductible, in their minds they think that they have to pay for everything, which they do, you know, for the first $1,250, and so they tend to not go to the doctor. And so our ER costs have risen, and that's who they kind of depend on to be their primary care physician is the ER. So while a high deductible is great in theory, there are some downsides to it. We designed this plan back in 1980, and it has basically stayed the same. So we never got into the whole copay market, and we don't believe that people value anything that they don't have to pay for, so we do not have anything that is $0. Our wellness benefit is that we waive the deductible, and all they have to pay is the 20% coinsurance. So they'll have to pay 20% on some things, but they never have a copay. And since in the last 10 years, we have experienced about a 3% overall growth in our medical claims, and we are very proud of that fact. So, you know, it's basically sicker people pay more, which I think is fairly fair. And one thing I want to, you know, kind of step back just a second and make sure that I'm leading you in the right direction. There's some things that I want to say that I want you to have as a takeaway, and one of those is that this process that I'm going to talk about is a step process. We did not just decide tomorrow that we wanted to open a patient-centered medical home. It was a process. And for those employers on the line, don't think that, you know, I'm ever going to give the impression that you need to go ahead and do this tomorrow. What I do think that you need to do is hear our journey and see where you fit into the line and take steps toward getting this for your employees. And the other thing is that opening an actual clinic is not your only solution, that there are creative ways to allow your employees to have access to a patient-centered medical home. But if you can just make those baby steps, you're going to see a great improvement in your overall health costs. So anyway, so let me continue. So who are our employees? We have about 1,250 employees. 89% of those are men. So I know you're shocked that we have people who don't go to the doctor, since we have 90% of our employees being male. 46% of them are between the ages of 30 and 45. So to me, that is family age. They have young children, and so they're distracted with everything else, and they're certainly not taking care of their own health. About 90% of our employees live within a 50-mile radius of themselves in central Louisiana. So we are fairly clustered in one spot, which is great for what we did. So that was very conducive to us. And about 70% of our employees are hourly. And we're a manufacturing facility, so you know, we're labor. We don't have a lot of college-educated employees within our employee ranks, but we do have quite a few. I took a poll about 2 years ago and found out that 80% of our employees had no primary care provider, and of the 20% that did say that they had a primary care provider, they named our medical directors that actually come on site as their primary care physician. So it was fairly obvious that they were not comfortable having someone that they could go to talk about their health needs. So in 2000, well, actually in 2000, we hired Ray Peters as our Vice President of Human Resources. And when Ray started and they were in a meeting, they were talking about our workers' comp cost. And we were hitting close to the $2 million mark, and he realized that if we just had an occupational health nurse on site that could basically kiss the bobo, make them feel better, let them go back to work, a simple splinter was costing us upwards of $1,000 once you figure out ER costs and everything else. And so in 2001, we did hire an occupational health nurse, and we saw an immediate reduction in our workers' comp costs. So that was a tremendously beneficial hire for our company, but also for our employees. And our occupational health nurse handles personal health as well as occupational health. And that has been a very, very positive opportunity or benefit for our employees. And our occupational health nurse at that time was Colleen Van Mall, and she still is. We have 3 occupational health nurses now, actually 4. And she initiated our Winning with Wellness program. And that is our wellness program for our employees. And our occupational health nurse handles personal health for our employees. And so I'm stressing that for a reason. In 2004, our occupational health nurse got together with 5 or 6 other occupational health nurses, and they created Wellness Works in Cenla, and that's what we call our area of central Louisiana is Cenla. And that was a group that tried to, and they were very successful. What they thought was, if we get employers together as sort of a buying co-op, we can put programs and ideas together for our employees and share the cost. So instead of buying 100 or 1,000 steamers or smoothie makers, we can buy 10,000, and then we'd have a cost saving. So that was very, very successful, and it actually got a $500,000 grant from the Robert Wood Johnson Foundation, and some local foundations donated money as well. And we were able to bring in smaller employers, and they ended up with about 40 or 45 small employers that couldn't afford to put a wellness program in on their own. So they were able to use Wellness Works and Cenla to start a wellness program. But when we had to start getting them to stand on their own, those small employers loved it for free, but kind of backed away when they had to actually pay for something. So if you ever get this idea and you think this is something that would work in your area, have them cost share at the very beginning, and that way you'll have some success. So in 2005, we started having a local doctor actually come on site to help with occupational and personal health issues. And our doctor stays there for an hour and a half, 1 day a week, and sees on average 20 to 25 people in that hour and a half. So it is a very popular benefit for our employees. But again, it is for our employees. And then in 2005, Katrina hit. And I'm talking about Katrina as we are facing floods again and worried about our levees again. So, you know, life is always an adventure in Louisiana. So when that happened in Katrina in 2005, the state of Louisiana had certain challenges because we have always had a charity hospital system, which I know no other state does, and it's so unusual for Louisiana to do something that no one else does. So, you know, the medical records were lost, the charity hospital was underwater, it was just a big mess, and so we knew that we needed to do something. And so we formed this Louisiana, well, we had a Louisiana Recovery Authority, and they were sort of in charge of trying to figure out how to recover in all areas of Louisiana, and one of those was health care. And they created the Louisiana Healthcare Quality Forum, and Ray Peters was selected to be on the board. And he actually flew up to Washington, D.C. and heard about this group called the Patient-Centered Primary Care Collaborative, and they talked about the medical home, and he started getting this idea that maybe this is something that would work for our company. And so when he came back, he told me to go and be a co-chair for the medical home payment pilot to figure out how employers would implement this and pay for it. And so, so I was on that committee, and it was quite interesting and challenging, and and I learned a lot. And then I became the board chair for the Louisiana Business Group on Health, and that gave me a wonderful perspective because our business group on health is comprised of health plans, employers, providers. We just have the whole gamut, consumers. We have everyone as a part of our business group on health, and so we have the ability to bring everybody to the table. And so in doing that, you start hearing about what other people are doing within the state and some of the creative ways that they are going about trying to reduce healthcare costs and trying to get their employees healthier. And that was a wonderful experience for me, just to give me a better perspective. And what I will say at this point is that employers need to get out of their boxes. We are all benefit people, HR people, CEOs. We have a CEO roundtable with the business group just to get the CEOs involved to say, this is what's going on in healthcare in Louisiana. And you need that. You cannot be creative in your own little box, in your own little office. You have to get out and see what other people are doing. Never would have thought to open a medical home had I not had these types of experiences. And so after learning how we could do all these things, we decided to make opening a medical home a priority. So Ray oversees health services, and he also oversees benefits. So Colleen and I got together, and it was our mission to bring the medical home concept to life. So we started wondering, how are we going to do this with we're not very big, and a lot of our employees live in Alexandria, but some of them live 50 miles away. So, you know, we needed to figure out how we could get that membership number up. And so we contacted local employers, and we didn't just contact anybody. We contacted employers that were owned locally, that had their management, their administrative services locally, and that had community, good standing in the community. And we wanted people who were self-insured. We preferred that because they just have more leniency. Everybody understood the concept. They got the concept. But guess what? We are snobs when it comes to offering health care to our employees, and I've learned that. People think if I open up a health unit for a clinic for my employees, they're not going to come because we make too much money, we have our own doctor, we're too good for this. And you, being a manufacturing facility, well, it's probably something that your employees would like. And I was kind of surprised by that reaction. And I'm happy to tell them personally, which I did the other day, that the people who are utilizing our clinic more than anyone are the people in the administrative office that I thought would be the least utilizers. So that perception needs to change. And people do think that it's going to be a clinic that we're opening. They don't understand that it's a medical home and there's a difference. And so that's part of the message that we tried to portray. And we ended up partnering with one other company, which was a locally owned, fully insured company. And that turned out to be a blessing in disguise because we were able to start small and not take on a huge amount of expense with a huge company coming in with us. And so when all was said and done, all the stresses of not having all these different employers ended up being the best thing that could have possibly happened. And so they're like size. Well, they're a little bit smaller than us, but they are fully insured, and that's a whole other talk to talk about the challenges. Not only are we self-insured and they're fully insured, we have Medco, they have Express Scripts. It was crazy. But anyway, it's working. So why we've chosen a medical home, which, I may be preaching to the choir here, we basically wanted to give access to quality care to our employees. That is the bottom line. We wanted to do it efficiently and effectively, and we felt we could do it best by doing it ourselves. And so, Louisiana is a poor state, and if healthcare reform goes through, 42% of our residents will be eligible for Medicaid. And if people think they can't get into the doctor now, it's going to be bad. I had an employee tell me that she had an appointment in January for her daughter's wellness visit. In February. It was February 23rd was her appointment. And they called her in January and told her that we're not going to be able to see your daughter in February. We're going to have to reschedule you for April, which is ridiculous. This is for a well visit. Are we all about prevention or what? And it just doesn't make any sense. Of course, there's a shortage of primary care doctors. Everybody's experiencing that. And we need for our employees to be at work, and we need for them to be focused on work, and we need for them to be productive. And they can't do that when they're sick, when their family member is sick, when they have something going on that they can't get to the doctor to take care of. And so for that whole host of reasons, just keeping them at work mentally is a big deal. That catchphrase, presenteeism, is not a joke. It really does matter, especially when you're in manufacturing with huge machines and you need somebody to not stick their hand in a conveyor belt. So anyway, so this was important for us. Let's see if I hit that hard enough. And we wanted quality care. We wanted electronic medical records. We thought that was vital. And a lot of people came to us with solutions that did not include electronic medical records, and we just were unwilling to settle for anything less. So we wanted that. We're a very technical company anyway. All of our stuff is state-of-the-art. Why would we want less in our medical home? So, so we did. That was something that was very important. And we needed to reach our dependents. Everything that we had done great for our employees. Our employees had access to medical care. Our employees had access to quality care. Our employees had access to a wellness program. But our dependents, Well, of course, I'm a numbers person, as Dwayne pointed out, and when I'm looking at our claims history and I'm looking at our claim data, I'm thinking, okay, it's the spouse that's killing us. It's the spouse that, we're not reaching, that have those chronic illnesses and things. And so we needed to be able to reach our dependents. And we wanted to build a structure for a medical neighborhood, which is our next move. Well, not our next move, but it's down the line. So after looking at all the models and the things that Louisiana has done and the things that we learned, we just felt as a company that we needed something that was designed to grow and change and adjust, and something that we could kind of have our hands on. And bottom line is we can't afford not to do it. We had a patient that came in with his family, and his wife had had diabetes for 21 years, and he would come home from work and she would be passed out on the floor, and he would give her syrup, and then after 4 hours or so she would come back to herself, is the terms that he used, and this is normal for them. Had no idea that because she had diabetes she was not supposed to be passing out. He thought that was part of the disease. And so we were able to get them in touch with the nutritionist through the medical home, and hopefully we have stopped an end-stage renal disease and dialysis. More importantly, we have added years to her life. Her daughter also has diabetes, and she had no idea. They had never had nutritional counseling ever since they've had diabetes. And so it was just heartbreaking and rewarding at the same time. So we can't afford to continue to let our employees and their dependents and not get quality care. So we created the Central Louisiana Family Health and Wellness Center, which we must have been on crack or something when we thought of that name, because it is a mouthful. And we've seen over 400 people, and it's mostly our employees. Gilchrist is our other employer, and they have not quite had the response that we've had for a number of reasons, which I'll go into if we have time. Our staff includes a physician's assistant, LPN, a medical assistant, and a receptionist. So we are literally bare bones. Gilchrist just hired a wellness coordinator that is housed at the clinic, and our occupational health nurse goes once a week to do wellness for our dependents. And our two medical directors that we have for our employees oversee the clinic, and one of them is on site 4 to 5 hours a week. And so they review every single chart and go over everything. So they're very involved in what's going on in the clinic. And so that's been great. They have actually done a few procedures there as well. So our employees feel like if they really have something that the physician's assistant can't handle, he will bring in one of the doctors, which is, has worked out really well. And we hired an outside party to run the clinic. So we don't actually run it. Turns out this is a good thing for a number of reasons. One of them is patient privacy. Patients have a real, we don't want our employees to think that this is a Royo Martin clinic, that we're going to be seeing what's going on with them, and we want them comfortable with the fact that it's private. Also, we have absolutely zero experience in running a health clinic, and probably in a few years maybe we'll feel comfortable enough to have an entity within the company that runs this, but we wanted somebody who had experience with it to do it for us, because we wanted it done right. And we don't have a pharmacy yet, but we are going, they're promising me we will have this by the end of the summer, and so our sense of urgency is urgent, I will say, and so we are going to make sure that that happens. So we saw 45 patients the first week, and one guy came in for a cold because he had a sinus infection and found out that he had an irregular heartbeat, and he actually did have to have a heart cath, and turned out that everything was fine. He had a little bit of blockage, and now he's on notice. And, these soft numbers, when it comes to employers, we try hard to put, what's the return on investment, what's the return, and when you have somebody who could have been a quadruple bypass or a double bypass, and now he can control it. He's on notice, and he feels healthier because he knows. You can't put a price on that. And this slide talks about the family with the diabetes. You know, those types of things are just invaluable. So, but we do feel like in the current world we do need to measure our return on investment. And so our metrics are basically looking at utilization. I can say on dollar, you know, Roy asked me this morning, how's our utilization? How much money is that saving me? You know that's going to be the question, even though he just finished telling me a success story that he had heard at the clinic. And he was like, you know, how many patients are we seeing? How much money is that saving us? And we've been open for 2 months, and just on doctor visits alone, we've saved about $30,000. And I don't think our utilization is where it needs to be because we're just starting. So you can just imagine if in the first month, we're 2 months, we're saving $30,000, how much we'll be saving by the end. But, you know, our ER utilization should go down. Our specialist appointments should go down. Our diagnostic testing should go down because they are doing all of our care coordination through the clinic. So if someone needs to go, like that guy who had to go to the cardiologist, he had an EKG at the clinic and was able to bring that to the cardiologist. But, of course, the cardiologist needed to do his own, which is going to happen, and my nurse tells me that's totally normal when it comes to EKGs, and so I just have to believe her since I'm not medical, I'm numbers. We should see our costs. You know, we'll measure our costs, primary care at the clinic versus the community. Primary care, a clinic visit versus an ER visit, those types of things. So those costs are comparable and measurable, and we will be looking at that. We hope to see a decrease in the severity of the issues that our patients that are at the clinic are receiving the right care at the right time. For example, that guy who had, you know, he's had a heart cath, but he knows now, okay, I've got some blockage, and he is monitoring it and controlling it with diet. He's aware of what's going on. So hopefully, you know, we won't see him with congestive heart failure whenever he turns 65. And once we get our pharmacy up and even before that, now even we are seeing where people are actually going and getting their medicine filled. We made an agreement with a pharmacy. We have a lot of people in Alexandria, and then 50 miles away is Natchitoches, and we have a large population in Natchitoches. And so what I did was I found a pharmacy in Natchitoches that has a medical staff actually at the pharmacy, and they can take people's blood pressure, read their blood sugar, and do those other things that on an ongoing basis some of our patients need. And so we cut the cost of filling a prescription at that particular pharmacy so that people don't have to drive all the way to Alexandria to do a follow-up. They can do a follow-up in Natchitoches. And so, because what we're worried about is compliance. And so we're hoping that that will help them go ahead and get that prescription filled until we can open up our own pharmacy. And, you know, more alignment with the proper provider, appropriate provider providing medication. Of course, you know, we have every doctor in the world giving all of our women here Loratab or whatever that is for craziness and hormones and whatever else that we women tend to get. So, you know, now we have somebody who's monitoring that at the clinic saying, yeah, you really need to call the EAP. You really need to talk to somebody who's more appropriate about figuring out what's wrong with you. In fact, one of our third biggest diagnostic group that we spend money on is gastroenterology and things like that. And so I was talking to our nurse about it, and I was like, I mean, what is the deal? And we live in Louisiana. Hello, we eat rich food. You know, that's who we are. And she said, no, it's depression. Whenever you're depressed, your stomach hurts. Your stomach hurts, you go to the doctor. You say, I have a stomach ache, and that's what that falls into. And when she said that, you know, headaches, we have a lot of headaches. Well, another thing for stress. And so we need to get the person to the proper provider. so hopefully we can start figuring out what's really going on with our employees. For the clinic, we're going to use evidence-based guidelines and evaluate those chronic patients to ensure compliance. And we're going to look at a compliance from the physician, from the patient, and from the clinic. So by the physician, are the correct tests being performed at the right time? Are our diabetics getting tested properly? Are they being referred to an optometrist to go and see, or an ophthalmologist to see about eye care, that type of thing? Are they seeing the nutritionist? And are you diarying it so that they will, you'll contact them to say, come on, you need to come back in for a follow-up. Patient, there's a lot of responsibility on the patient part. It is a patient-centered medical home, and part of it is teaching our patients to be self-reliant and responsible for their own health. So are they keeping their appointments? Are they taking their medication? Is the patient compliant with care as outlined? That's easy. And by the clinic, is our care coordinator actually following up with the patient? Are they reviewing the records? Are they making sure that they are following up? Are the results being logged? Is our utilization increasing? Are people happy coming to the clinic? And do they want to come back? Are they telling their friends? I told the staff at the very beginning, I said, if somebody comes in and has a positive experience, they're going to tell 3 people. If they have a negative experience, they're going to tell 20. This is just human nature, and it's just the way it goes. So it is on you to make sure that they have a positive experience. And then what we did, we have HRA, health risk assessments, already done for our employees, and so we have a baseline. And so we'll hope that when we do yearly health risk assessments, well, we have them only for our employees, not for our patients. So we're working on this part. Let me just say that. I'm not going to say that we're doing a health risk assessment on everybody who walks in the door, but if they come in for a wellness visit, we do. And then see if that's improving over time. And we do have satisfaction surveys, which so far have been very positive. So we are really happy about that. I will say that our bug man came in yesterday to spray for bugs, which if any of you are from the north, you don't understand about that. But if you're from the south, you do. And he was wondering if the bug man could go to the clinic because they don't have any health care, and he was thinking that it was such a wonderful thing that Royal Martin is doing for their employees. So that goodwill that we have received, not just from our employees and their families, but from the community, has just been unbelievable. And our clinic is gorgeous. In fact, I thought yesterday I should have put some pictures of the clinic into my slide so that you could see it, because it is spectacular. And our employees pay $12 to go to the clinic, and that includes anything that's done there. Blood work, that EKG, anything like that is all included in their $12. There's a clinic on the other side of the building, and we're going to share an x-ray machine with them hopefully soon. And, all that will be included. So it is cost effective. Again, we have co-insurance and deductibles, and so for them to be able to pay $12 instead of, they pay $350 to go to the pediatrician. It's insane. And they do immunizations at the clinic and different things like that. And, in fact, at the very beginning, this one little girl had gone there, and the mother was telling me how thorough the exam was. She said, I have never witnessed my daughter having such a thorough exam, and she was just going on, and the little girl piped up and said, and I got well. I was like, well, I guess that sort of sums it up. That is what it's all about, is that you actually go there and you do get well. So with that, I have taken up 45 minutes, which kind of surprises me, but I have a lot to say. So I guess it is time for questions.
That's great. Diane, can you hear me? This is Rob.
Yeah.
Oh, great. Excellent. Excellent presentation. Just to remind everybody, go right ahead. If you have a question, type it in to the the section which usually I think appears on the right-hand side under questions. You could just place them on there, and we'll gather them up and ask your question on your behalf. While we're waiting, Diane, one of the questions we often get and try to address is the incentives for to get employees engaged. Can you expand upon some of the points you made about that, and maybe walk us through how that how you go about determining those incentives and what they look like?
Yeah, well, first of all, we did not raise our premiums at all to include the patient-centered medical home. Our employees pay $12, which is not a copay. What we said was it would probably cost you about $60 to go to the clinic, and so 20% of that would be $12. So that's how we reached our $12. So we told them it was a fee and not a copay. And anybody who is covered under our insurance can go to the clinic. And we stopped it at that because we did not want to be overrun, and we didn't want to have to deal with other people's insurance. And so right now, the only people that can go to the clinic are the people that are actually covered under our plan. And we already have employees that are complaining about that, which I said, well, then you should be on our insurance because it's better. But anyway, and so that is a huge incentive for us. On our wellness program, we have incentives. They get the employee portion of their insurance paid for the year, which is $3.35, and then they get a $100 gift card to Academy. Mm-hmm. And so that's the incentive. And the way we do our wellness program is that people can set goals, and they can set 6 or they can set 10. It doesn't really matter, but they have to reach at least 3 goals, do one participatory thing, go to some meeting or something like that. And if they reach those 3 goals and participate in one thing, then they get the full incentive. And their goals can be, I want to lose weight, I want to lose 5 pounds, I want to maintain my blood pressure because it's at a healthy level, whatever it is that they want to do. And then the occupational health nurses actually sit down with them and say, it is unreasonable for you to think that you can lose 100 pounds in a year. So that is not a reasonable goal. You need to make something reasonable. And so we kind of monitor it like that. Does that answer your question?
Yes. Yes, thanks, Diane. I'm going to turn to the questions that are being submitted, and I will tell you this, in the remaining time, we definitely do not have enough time to cover the amount of questions that have been posed. So it's good to see there's so much interest out there. So thank you, everybody, for asking very good questions. Here's one. Are all primary care physicians in the community allowed to be accessed, or only select ones?
Anyone in our community can be accessed. We're actually, the company that we're using is a subsidiary of one of our hospitals, and we have doctors that are associated with that hospital and doctors that are associated with the other hospital. And we have been adamant in the fact that we want to engage all providers that are using evidence-based, good practices. And that's determined by how well our employees get when they see them. So
good.
That's the way we've approached it.
Great. Thanks, Diane. Another one, interesting question here as you were embarking on your journey to establish a medical home. Did you consider linking your employees with another medical home that perhaps already was in existence, assuming there was one out there, instead of creating it and going through the effort that you did?
We did. We didn't have a medical home here. We thought about trying to. One of our medical directors is actually a family care doctor, and his office is attached to a pharmacy, and it's sort of a medical home concept that we thought about using, but we wanted something exclusive. We wanted something that only our employees could go to. We didn't want to fight because of the access issue, and we just thought that because of really just for the access, it was better to do something exclusive. So that's why we chose to go the different route.
Good, good. Thank you. A comment and then a question post. The comment, I'll quote, "Impressive job, well done, and good for you guys to recognize the importance of primary care and prevention." So I thought I'd put that little compliment in for you, Diane. A specific question about the clinic, just for clarification, was the clinic on site? And the reason they asked is you said there was another clinic down the hall, so maybe you could just clarify how the clinic worked.
Sure. It is centrally located with our employee base. We did a zip code analysis, and it is not on site. Both of our facilities are sort of, I don't know, in the middle of nowhere. So they're in between communities, and so our employees live here in Alexandria, which is the middle. And then we have some, again, like are 50 miles away, some that are 30 miles away. So it is not on-site, it is centrally located. And it is in a building that we actually owned. One half of the building is a clinic with two doctors, two primary care doctors. And so the other half of the building was empty. So we remodeled the other half of the building, and so half of it is our clinic and the other half is a primary care clinic. And so we opened up a door in between the two clinics, which we will utilize once the x-ray is open. So there is no relationship between the two entities except for that.
Gotcha. Good. Thanks, Diane. Here's a question. As we have callers from all over the country, and people who participate in the PCPCC, there's really no boundaries. I think it's even expanding out beyond the U.S. But think about the various markets that are out there. Here's one coming in from a completely different market, which has several small self-insured employers that would not set up their own clinics, but they could get involved in partnering with health plans to support medical home initiatives. How would you, Diane, engage those employers in getting more involved? And as you're thinking about that, what would be their return on investment, since they already feel they're paying a lot for their health care? So two-part question: how would you get them? How would you get them engaged? And then also, from an ROI perspective, what's your thoughts on that?
Okay, well, I will get on my soapbox for just 1 second and say we actually had this conversation when we were organizing this. I believe that the employer is the payer. And we always call health plans payers, but they're not. They're being paid by us. And, you know, I would say small employers need to understand that even if they have 50 or 100 employees, they have power in that because they want their business, but you know, people talk, and employers need to understand that they do have the power, and so they need to get together. And we could not have done this without Blue Cross. Blue Cross was a big player in this because the other entity is fully insured, and they were on board with us and made all kinds of things happen because they can see this as a tool for themselves to create a model that they can market, because they have to start controlling costs as well. And so they cannot keep hitting you with 17% premium increases, and they know that. I mean, there is a saturation point, and they're going to have to start figuring out more creative ways to pay providers, and that's something that I didn't really touch on. But employers are smart enough to understand that paying less isn't always the answer. I would rather pay $50 a time for my employee to have to go to the doctor twice than $1 a time and have him go 100. And, you know, so employers need to tell the health plans that we have another agenda, and the agenda is to look at outcomes. And so you start holding their feet to the fire and say, thank you, Blue Cross, for the wonderful job you're doing in getting my fee-for-service down, but what are you doing about making my people well? Because you're not doing the job for me if you're not getting my people well. And start going at it that way, and when you start trying to say, I want results on this, then they're going to start changing the way that they do business, and that's the only way that you can do it. Put it in your contract. You need outcomes. So,
Right. Great.
Was that both questions?
Yeah, so the first was the engagement, the second was the ROI. So, yeah.
Yeah, ROI, you know, it's just a hard thing when it comes to healthcare. I'm sorry. You know, employers are just going to have to understand that it's about more than, it's about dollars, but it's about more than dollars. It's about those future dollars that you can't really measure.
So it's a long-term investment.
It is.
Mm-hmm.
We made a 3-year commitment to the medical home at a minimum. And let me just interject. I saw somebody said, well, we partner with more companies in the future. And honestly, what I think we want to do is allow small employers to come into our clinic, and they can probably afford a catastrophic plan, and their employees just want to be able to go to the doctor when they have a cold. Come on. And so that's what we decided was, let's do a per member per month type thing and let smaller employers have access to the clinic, and that way it's not overrun by a bunch of people, but also it's making an impact on the community, because now we have those people who couldn't afford health care before access to care.
Right.
And that'll be a revenue source for the clinic.
Gotcha. Good. Another question. And I don't recall hearing this throughout your presentation, so if it's redundant, I apologize. Can employees use their work time for appointments, for medical appointments? And then do you think that the model would work as well for employers who are more spread out than you are over larger geography?
It's a tough one. Well, what we did was we modeled it. Our hours are Monday, Wednesday, and Friday, 7 to 4, Tuesday and Thursday from noon till 8 at night, and then Saturday 9 to 1. So no, not really. Like, our clinic is 3 blocks from our administrative office, so our administrative office goes there during work hours, and that's fine. We don't dock them for that. But as far as our other employees, they pretty much have to go on their days off. And we're a 24-hour, 7-day-a-week type of operation. Our employees work 3 days. They're off 2. They work 3. So they have time to go to the clinic on off days. So no,
and the practice,
they really can't.
And Diane, the practice staff, they're employed by
They're
whom?
employed by HCA, so they are employed by
Separate.
someone else. And they actually can't go to the clinic for care. So
You can't?
They can't.
Oh, okay, gotcha.
Yeah, but they do. But they're really,
Yeah.
So that's how we worked it out. So kind of no, they can't really go during. Yes and no.
Mm-hmm. And then for employers that are more spread out geographically, model.
Yeah.
What's your thoughts on that?
Well, I actually have a good friend who's got 3,000 employees, and her biggest facility has less than 200. So they're spread out all over the country. And what I would suggest to her is, and what I did suggest to her, is to find a primary care clinic that they can start changing the way that they pay that provider and give them a monthly fee to let their employees go there and have access, and try to work out a way that's beneficial for them to start bringing up the level of primary care for their employees, and just engage a provider. I think that that's a good solution for those that don't have a concentration of employees.
Right. Good.
Does that make sense?
Yes. There's a question about hospital care. If hospital care is needed, do the employees access any of the, in this case, the Blue Cross Blue Shield network hospital?
Yeah. Anything that's, for example, we have the guy who had the cardiology issue. He was referred to a cardiologist. At that point, their regular benefit package goes into play, and they would, again, pay their deductible and their coinsurance just as they would any other time. So anything that's outside of the clinic is their normal benefit structure. Anything in the clinic is $12. Now, the way that Gilchrist structured it is that their employees pay the regular price, so they pay about $65 to come to the clinic, but they have an HRA. We have an FSA, a flexible spending account. They have an HRA, and they're immediately reimbursed when they come to the clinic, so that it really kind of only costs them half price. So that's the way that they worked it. And then anything outside the clinic is their regular. So.
Good, thanks. And speaking of hospitals, how do you communicate with hospitals for that, especially the transition of care, which is all, a major area of concern, as well as I think opportunity for all of us to do a better job with.
Right. Well, we do have an advantage in that HCA owns one of our hospitals, and this company that we are partnering with is HCA as well. So they have electronic medical records that can talk. So they can get things electronically from the outside sources. Otherwise, doctors can fax data and information into our clinic, and it goes directly into their electronic medical record. And so our staff is calling the other providers to get that information, since they're setting up the appointments. And so there's back and forth conversations like that. And so that's the way that they're communicating and getting the data.
Great. We're at the hour now at 4 o'clock, at least on the East Coast, Diane. Any closing comments, thoughts by you? What advice, if you had to kind of narrow it down to one or two bullet points for the audience out there, which is comprised of many employers who are trying to and are focused on wellness and keeping their employees healthy and more productive, in light of today's discussion and the work and experience that you have. Any closing thoughts for the audience to think about?
I would say get involved in your state. You would not believe what some of the employers are doing. They are creative, they are thinking, and they are finding ways around this. And not everyone has 100% of the answer that you need, but somebody has a germ of an idea that can take off for you, just like this did for us. So that is the number one thing, is that you need to get involved in your state organizations. Number two is, don't think that you need to open up a clinic tomorrow. Start by hiring an occupational health nurse. Start by trying to address those health issues that your employees have, and take it from there and let it grow on its own. It is an organism that grows, and so take baby steps, but start walking.
Great. Well, thank you very much, Diane, on behalf of the Center for Employer Engagement and also on behalf of the Patient-Centered Primary Care Collaborative. We thank you for joining us today on the webinar, and we thank everybody who tuned in for this webinar, and we hope to bring some more topics down the road in the webinar format sometime in the future to all of you who are interested in this topic of employer engagement in the context of the patient-centered medical home. So thanks again, Diane. Take care, everybody.
Thank you. Thank you. Bye-bye.